So now, complicating the discussion of first-line treatment in gastric cancer is the advent of immunotherapy drugs. We now have approval in the West for pembrolizumab, the anti-PD-1 drug, and in Japan there is approval for nivolumab, an anti-PD-1 drug. And both of these approvals are really in the refractory disease setting. We'll talk about later line therapy in a bit, but first line, we have results from the KEYNOTE-62 trial, which was a first line trial in PD-L1 positive patients, 1% or higher, a head-to-head comparison of chemotherapy alone, fluorinated pyrimidine platinum, chemotherapy plus pembrolizumab, or pembrolizumab alone. And what we saw from this study is comparing chemotherapy with or without pembrolizumab, there was really no meaningful difference for combining an immunotherapy drug upfront with chemotherapy compared to chemotherapy alone. There was a slightly higher response rate, but no meaningful differences in progression-free and overall survival. So really arguing against the combination of an immunotherapy drug with first-line chemotherapy. And also interestingly, in the chemo alone versus chemo plus immunotherapy, there was no difference in terms of CPS or PD-L1 score. If you look at the 1% or the 10% or higher patients, there still was no benefit for adding immunotherapy to chemotherapy upfront compared to chemotherapy alone. The exception would be patients who are MSI high. That was a very small percentage of patients on KEYNOTE-62. It was only about 6 or 7% of patients. But in those patients, the checkpoint inhibitor may behave better than chemotherapy as first-line treatment. Higher response rates, more durable response, median survival wasn't even reached. So the exception in first-line treatment would be consideration as a possibility for using drugs like pembrolizumab as first-line treatment for MSI high patients. These patients have exceptionally high response rates, durable response. And also on that trial, there was evaluation in MSI high patients of immunotherapy plus chemotherapy. And there, it didn't seem that chemotherapy added to the immunotherapy. So I think the exception would be MSI high patients. Now, we have to remember that sometimes when our patients with advanced metastatic disease walk in the door, we don't have results back from mismatch repair studies or MSI status or genomic profiling. So my suspicion would be that these patients would start with chemotherapy, and then if we detected that they're mismatch repair deficient or MSI high, we might have consideration to transition them to immunotherapy. It's not clear whether combining chemotherapy with immunotherapy is any better than immunotherapy alone. So a first-line setting would be the MSI high patients, but knowing that when they walk in the door, we don't have results of that testing, and we would often start them on chemotherapy and then consider earlier line use of immunotherapy drugs in the MSI high population.
As you know, in KEYNOTE-062 trial demonstrated non-inferiority of overall survival in pembrolizumab monotherapy compared to standard chemotherapy for CPS 1 or higher cohort. In addition, the Forrester plots in subgroup analysis for OS shows clear benefit in Asia, contrast to the West. The trend is more pronounced in patients with CPS 10 or higher. Furthermore, MSI high population, which occur only 5% of the time in advanced recurrent gastric cancer, have a clear benefit from IO therapy in this population. So when IO is used as a first line, MSI high is the most promising biomarker in the case of a single agent of IO, and CPS 1 or higher, especially CPS 10 and above, are also promising biomarkers.
In the second line setting, specifically with respect to immunotherapy, MSI high, of course, as we just mentioned, is the standard option for patients in the second line if they've not already had exposure to immunotherapy earlier. The other subgroup of patients that may benefit based on the Keynote 61 study, which is a randomized study of paclitaxel or pembrolizumab open label, in a subgroup analysis, it appeared that in addition to MSI high tumors, that patients with higher levels of PD-L1 expression, CPS score of 10 or higher specifically, in that study showed that there seemed to be a benefit. In other subgroup analyses of other studies, say Keynote 62, um, uh, this was not the same. There was this yin-yang effect, even in the CPS 10 or higher in the Keynote 62 study, comparing the pembrolizumab monotherapy to the chemotherapy arm. And so whether or not CPS 10 is the optimal cutoff, I think, is yet to be determined. These have all been sort of retrospective, unplanned analyses in small subgroups that are subject to a lot of random variation. And so in one study we see benefit, in another study we don't. But I think that the general trend that we consistently see is that after excluding MSI high tumors, so amongst the MSS patients, that the higher the level of CPS score, the higher the probability that a patient will benefit. It's not guaranteed that they will benefit at a very high level of CPS 90, for example, but they have a really good chance. And the lower the level, the lower the chance, to the point where if you're less than 1, you have a very low, if at all, chance of driving benefit. So again, it's more of a linear parameter. And we like to think in a binary fashion, yes, no, positive, negative, where we have to make cutoffs, but ultimately that's going to be subject to false negatives and false positives at any cutoff level. Whether 10 is the optimal cutoff or maybe even higher, I think is yet to be determined. But I think that one day we will be, in addition to MSI high tumors, be offering monotherapy checkpoint blockade to this optimal subgroup that we can define, if not in second line, not in first line, at some point early in their disease course, because I think that would be best for those subgroup patients.